All right, we're going live in 5, 4, 3, 2.
Great. We'll just give a couple minutes for
We are
everybody
live.
to join. Okay, great. Thanks everybody for joining us today for this month's Miami Global Brain Tumor Symposium. We have a very special keynote speaker today that we'll get to in just a second. So today is our 50th Miami Global Brain Tumor Symposium. Very much lucky to have my co-directors and everybody that's been supportive of this program over the last 2.5 years. Couldn't do this without Dr. Komatar, Dr. Morkos, and Dr. Benjamin, and also now Dr. Shah, who's all been instrumental in kind of helping me put this together, as well as our administration here at the University of Miami, the Cancer Center, as well as the Department of Neurosurgery. So thank them as well. Any questions about these conferences, Zoom-posiums, please be sure to follow us on social media. Check out our website. For instance, tomorrow, Dr. Morkos is having a great skull-based and cerebrovascular symposium on AVMs, and I encourage you all to check that out as well as we continue with the skull-based cerebrovascular and brain tumor symposiums every month. They're all recorded and located on YouTube, and you can go back and watch them. We've had over 10,000 views thus far. So please, we try to make this as interactive as possible. Use the Q&A buttons, and we'll try to get all the questions at the end of Dr. Yang's talk today. Also, please be sure to like, share, and follow us on social media. This week, we have returning panelists, Dr. Shah, Dr. Berry, Dr. Dagobati, and Dr. Morel, all from the University of Miami, who will be joining us to discuss today's talk, as well as discuss some cases if we have time. But most importantly is tonight's speaker. Dr. Yang is really important in my life. He's probably one of my most important mentors, going back now almost 15 years. He was my chief resident at UCSF, so everything good and everything bad that I've ever learned has started with Dr. Yang. But he did his undergraduate at Berkeley, went to UCSF, did medical school at UCLA, UCSF, and now he's back at UCLA, where he's just been a tremendous impact and teacher to the students. He has too many awards and talks and really just prestigious events in his life to kind of go through in just a short time. But he just take my word for it. He's definitely one of the best mentors, teachers, leadership models, and surgeons that I know. And on top of all that, he has a very productive research lab that focuses on meningiomas, vestibular phenomas, gliomas, and similar cervical canal dehiscence, and so and leads an army of medical students, residents, and fellows at UCLA to do his important work. So I just want to thank him. It's the middle of the day out west, for taking time out in the middle of his day to give us his talk today. So Isaac, thanks so much.
I'm speechless. Mike, thank you so much for inviting me. And I'm genuinely speechless, and I usually always have a lot to say. I mean, you're just making me choke up. I don't know what to say. I mean, that's just the nicest introduction I think I've ever had. And yeah, Mike, thank you for inviting me. Mike was, I don't know, we were residents together, and just watching Mike Ivan and Rick Komatar and Jack Morkos and now Carolina Benjamin at the Miami program. They're all friends of mine, and just especially to watch Mike Ivan become the superstar that he is, and I knew he was even back then. I'm just so immensely proud to watch you way supersede me, and it's just natural. So you're an all-star. So thank you so much for those kind words. Thank you for having me. And so Mike did ask me to talk about the MG, about brain tumors here. And I've watched a lot. I've caught as many as I can. I think it's revolutionary, first of all. He said, like the social media, Instagram, this all, I think, started with the pandemic and COVID and when things shut down. And this really revolutionized neurosurgery education. And I think it's going to stay forever. And even as we open back up, these kind of events are so important. Like right now, it's in the middle of the day here in California, end of the day for all you in Florida. But this is pulling us all together in the middle of the week on a Wednesday for us to have these conferences where back in the day, in the 70s and 80s, you had to be at CNS or AANS, or you had to be at a meeting for these things to happen. And so I just applaud them for this effort. And so there's been 50 of these. This is the 50th MGBTS. And by the time you get to 50, man, there's not many topics left that you can talk about that haven't been talked about. And I've been wonderfully happy to be a part of some panels. And I know last time I was here, I was talking about acoustics, but I was looking for a topic that hasn't been touched on, but still has a lot of legs and would still be really interesting to the brain tumor community. So I chose the role of preoperative embolization in meningioma surgery. So we're going to talk about meningioma surgery and the role of preoperative embolization, a kind of a twist on something that we all normally talk about. Now, to quickly go through the basics for maybe some of the medical students or residents also on the call or fellows here on the Zoom, meningiomas, one of the most common CNS tumors, in addition to metastases and glioblastomas. For the boards, they originate from arachnoid cap cells. I don't know, when I see Mike, I go back to being a resident going, oh my God, I gotta study for the written boards and know all these esoteric facts. They're typically slow-growing tumors. They're more common in women, 2 to 1, but the atypical and the rare tumors are actually have a higher predominance in men. So when you see a male patient who has a meningioma, your worrisome differential bar for an atypical or an anaplastic meningioma has to be a bit lower because they're more common in males. But the sheer overwhelming number, they're more common in women versus men. And they're graded in 3 ways, the good, the bad, and the ugly. Grade 1, 80% of them are benign tumors with a very low recurrence rate. Grade 2s are more atypical, more aggressive with a slightly higher recurrence rate. And grade 3, those are cancer, and those are really bad. And so when I was thinking about this talk about embolization, I had to think about my residency, and Mike is dating us now, like we're so old. But if you go back 15, 20 years, back to the beginning and back to meningiomas, and I had so many good teachers at UCSF, including Mitch Berger, Andy Parsa, Mike Lawton, Nick Barbaro. I had so many good people, but in particular, the man who taught me a lot about meningiomas was Andy Parsa, who passed away in 2015. And Andy used to tell me, Isaac, don't be afraid of failure. I think he said this because I failed a lot, and I still do, actually. Don't be afraid of failure. He said, be afraid of succeeding at the wrong things. And when I look at meningiomas and embolization for this, what I learned from Andy was that he embolized, I think, almost every meningioma. Mike will have to attest for it, but his embolization rate from meningioma was really, really high, very high percentage rate. Like 80, 90, I don't know. It's probably skewed in my memory, but in my residence, I just felt like he embolized 100% of his meningiomas. That's probably not true, but that's the way I viewed it. And then Neil Martin, he was the chair here at UCLA. He hired me. And when I came in, Neil Martin was such a good surgeon. He was so precise, so technically gifted, and so intense about the way he approached it. And when I saw him, he also embolized a high percentage of his meningiomas. So when I got to my practice, I said, you know what? We just make surgery safer by embolizing everyone. That's the approach. I have meningiomas. I'm going to embolize all of them. There's a slight problem to that approach, if you can probably foresee it. Not everyone needs an embolization. And which ones do you need to embolize? And if you're trying to embolize them, what is it that you're trying to prevent? What are you trying to study? So the first thing we wanted to study was blood transfusions. We took all our meningioma surgeries, just meningiomas only, all grades of meningiomas, and we were saying which one of these patients got transfused blood and which one of them made an impact on their transfusions. Now, if you stop and think about it, you're like, Isaac, that's got to be the weakest, lamest research question of all time. It's a blood transfusion. You're a surgeon. Who cares? But if you actually stop and try to think about it, it's really hard to study transfusions. It's really hard to study them because you have to have a pre-operative hemoglobin and hematocrit. You have to have a timing before of when the transfusion occurs. And then you have to have a post-transfusion hematocrit. And so we did a retrospective analysis. We looked at all of our meningioma surgery, and this is how we did it. We had a days from transfusion. You have to follow the hematocrit from before the transfusion, and we have to follow the transfusion afterward. The first thing we found out was that you can use a very aggressive transfusion rate. So you can try to keep the hemoglobin lower and the hematocrit lower without many untoward effects. But the other thing we found was that if you transfuse, there aren't too many adverse events from transfusions. And so we try to keep our transfusions low and limited at UCLA. We're pretty aggressive about the way we use our blood. But what we found is when we use it, it's also pretty safe. And so this is the way we had to study. This is actually quite complicated and difficult, is that we had to actually follow their crits around the times of the surgeries. Some of them did not have those checked at the right time. And then we had to control for the timing of the transfusion for them. Ultimately, we found out two different things. For transfusions, there's something called the 30-10 rule, the hemoglobin of 10, hematocrit of 30. And you could try to push that down to 824, 927. You know, we aim for something like that, 8, 9, 24, 27 hematocrit. But for meningiomas, we actually found something called the 5-10 rule. When your meningiomas were 5 centimeters or larger, or your operative time was approaching 10 hours, your risk for transfusion is significantly greater. That the bigger the tumors, the risk of your transfusion is higher, and the longer the surgeries are, that these risks are higher. And that these things were correlated with an increased length of stay and non-routine discharge. So you could easily just say, well, then it's just the bigger tumors that needed it and the longer surgeries. And so we found that larger tumors that have longer operative times and older patients, these are the patients that needed transfusions and that they needed hemoglobin transfusions, and that this created the 10-5 rule. And for us, when we first looked at it, I was like, great. It's safe to follow an 824 transfusion risk. When you give transfusions, it's safe. But really, are we just finding that bigger tumors and longer surgeries are not in transfusions? And does embolization make any rate to the rate of transfusion? And what we initially found was that it didn't make a big difference, that whether you embolized or not didn't significantly alter our transfusion rate. And so if you want the details for this was published by Dr. Al-Khalid, who's now a neurosurgery resident in Georgia, and Dr. Logman, who's a neurosurgery resident in Cleveland, in Ohio. And so we published this for the results of looking at transfusions. But the question that catapulted us from this was back to the original question from Andy and from Neil, from Dr. Parson and Dr. Martin, which is, well, if transfusions are something we're trying to avoid, does embolization help at all? And so our research team here at UCLA, very, very, very smart research fellows and medical students and residents, came up with something called the Meningioma Vascularity Index, MVI for short. And what we did was, if you could look at all these tumors, and medical students and residents are commonly asked on meningiomas, can you see flow voids? And can you see blood vessels? And that's a common question we asked. And we thought, if you could volumetrically analyze all these in an easy way with ITK Snap software, you'll see, I'll go through the details here in a bit. If we could volumetrically assess the flow voids to get a biomarker, essentially a snapshot of how vascular the tumor is, can that help us predict how much blood you're going to lose, and should these patients get embolization? And this is how this works. And the reason why I thought this was useful, because when I look at, and all these meningiomas are meningiomas that we resected and that I did surgery on. When I look at this right frontal intraventricular meningioma, I frankly cannot tell how vascular it is. But when you do the MVI analysis here is less than 2.5 cc's. You can see the red segmentation for the flow voids that we're giving this to this particular tumor. Conversely, if you want to compare this to this left atrial meningioma, intraventricular meningiomas, and not all the meningiomas were intraventricular, but these two are, that this MVI was greater than 2.5 cc's. And all you could really say was this tumor is larger and there's a little more peritumoral edema. But I would argue that this one here is a left sphenoid wing meningioma. And when we did the MVI analysis for this tumor, even though this tumor is a little bit smaller than the previous tumor, this MVI is also greater than 2.5 cc's. And so it's not straightforward analysis. And so, So these are these images now. And so we did this for all these meningiomas. And these are convexity meningiomas here. You can see this is a frontal meningioma, an occipital parafalcine meningioma. You can do this to all these meningiomas. And using the ITK SNAP software, this is semi-automated volumetric analysis. So when you look at these tumors, can you give an assessment for how vascular they are? And so the MVI is what we use to do it. And so we call this MVI semi-automated volumetric analysis because the computer software will do this. And so let me play this video to show you the computer segmentation. So this is from ITK SNAP version 3.4, which is publicly and widely available and free. Oh, let me just start that again. And so here is a meningioma, a planum meningioma that you can easily see, but the computer itself doesn't know a meningioma that's different from blood vessels or different from sinuses. And we have to essentially give it the parameters to start the segmentation. And so the tumor borders are then identified. And then the software, based on these segmentation thresholds, automatically segments for what is tumor and what is not tumor. And so here the tumor segmentation is semi-automated because we're adjusting the thresholds, but now the software identifies the tumor. And then on the backside, we make sure that the computer software, the AI, the software doesn't incorrectly segment these tumors. And then once that is done, then you can do a T2 flow void analysis to identify the MVI. And that's all free and publicly available software that you can do as soon as this talk is over. Just download the software, the ITK SNAP software. And so the first thing we found was that the MVI was very important for intraoperative blood loss. So that if the MVI was higher, your estimated blood loss was higher. So for the non-embolized cases, MVI was very important for predicting blood loss, and very important for predicting how much operative time, how many complications might occur, and how badly the patient would need a transfusion, because the MVI was really important. But what was we found on the flip side of this, so the MVI correlated with intraoperative blood loss when you control for tumor volume. So even on the small tumors that had high MVIs, the blood loss was going to be higher, and the risk for blood transfusion was going to be higher. But on the flip side, what we found was that the MVI accurately predicted which patients could benefit from embolization. That if the patient received embolization on the MVI, their blood loss was not significantly increased. So if you looked at any two tumors controlling for tumor size, if the MVI was higher, you would expect that patient in that case to have higher blood loss. But when we embolized those cases, the blood loss was same, that you mitigated the effect of an elevated MVI. And so this changed the way we approached meningiomas and meningioma surgery here in my practice, is that we would look at these tumors, these meningiomas, and assess their MVI. And if their MVI was greater than 2.5, and now we're down to 2.01, that was the cutoff point. If it's greater than 2 cc's, that those patients are the ones that we would put through the angioembolization process, and that it would make the surgery better with less blood loss and a lower risk for transfusion. Conversely, if we found that the MVI was low, no matter how big the tumor was, we would not embolize these patients because those tumors probably wouldn't benefit. And so we published this in the Journal of Neurosurgery, and you can see the details here with the team here. And you can see Dr. Romeo here is a resident now at Rochester, and Dr. Nguyen is at UCSF and Stanford. Dr. Ong here is at University of Hawaii. So we've now, these slides are moving too fast. So what we've now done if my slides will stop, is that we've now looked at 85 patients. That initial cohort was done with a small number of meningiomas. We've now expanded this study to 85 patients that have had surgery, and we're able to control and compare for a lot more confounding variables. And the biggest one that would come to mind is tumor volume. What we wanted to identify was, is MVI just a biomarker for tumor size? Can you just embolize the big tumors and leave the small tumors alone? And what we found was, no, it's not true. And I'm sure Mike will attest to this fact, and all the meningioma surgeons who've done a lot, sometimes there's these giant, big honking tumors, and they're just rocks. They're just calcified. They don't bleed. There's no MVI on them. Sometimes there's these tiny tumors that have a high MVI, and they just bleed and bleed. And all you can do is take out more tumor. And sometimes when you're in the middle of the bleeding, the only way out of the bleeding is to resect the entire tumor. And so I think that this is a separate corollary, that when we look at meningiomas, there's not just grade 1, grade 2, grade 3 pathologically. What we're going to find, what the next generation of meningioma neurosurgeons are going to find, is that, yeah, that's a meningioma and that's a bloody one. And we're not just looking at T2 clefts and brain margins, and is it clean margins or spherical or regular margins. We're going to be able to tell. There's going to be a computer software algorithm that says that's a meningioma and that's going to be a bloody one. That's a meningioma and that's going to be not so bloody meningioma. And so this is the data in which we found. And so a few things. One, we found that MVIs greater than 2 cc's correlate with two things. First of all, it did correlate with tumor volume, but the second thing it correlates with is operative time, that these bloody tumors, and these were all done in retrospect. So these tumors didn't have their MVI done in prospective fashion. We were doing these MVIs in retrospective fashion. But when we're looking at it, these surgeons had to take longer time, greater hemoglobin drop, greater blood transfusion risk, and a higher tumor volume in these patients that had a higher MVI. And so when you control for MVI, you saw that the greater the MVI, the greater the estimated blood loss. And that this control core, even in this larger series, could be mitigated with embolization. So that if you embolize the higher MVI meningiomas, your blood loss approached the lower MVI tumors. And then the last thing is the tumor size. So this is a multivariate analysis. And what we found was that the MVI was actually more important than tumor size when controlling for tumor size. So that the MVI was more important for blood loss, EBL, transfusion risk when you control for tumor size. Because really the crux of it was, is it just the bigger tumors? And the answer is no. Even smaller tumors, like that smaller intraventricular tumor with a higher MVI, those tumors are going to be the bloody meningiomas. And I think as we move forward, as the software and the algorithms get better and better, we're going to be able to get those reports preoperatively so that we'll be able to analyze these tumors and quickly be able to assess which one of these tumors need to be embolized. So it's my recommendation that embolization be recommended not for all tumors. I hope that I have not been afraid of failure and that I've pushed beyond what Dr. Parsa and Dr. Martin taught me, which is embolizing every tumor. But that the next step would be, no, we don't need to embolize every tumor. We don't even need to embolize every large tumor. We need to be able to look at the tumor differently. And if we could assess its vascularity, only embolize those tumors with an elevated MVI. And so that this MVI can be a predictor for how much blood you're going to lose. If the surgery approaches 10 hours or 5 centimeters, it's probably going to need it. And that embolization can lower your blood loss dramatically. And that this is a non-invasive radiologic marker. You can gauge the vascularity and help determine postoperative care. Now, if I were one of the younger people here on this call and, just being sarcastic, and Mike may be thinking this, okay, Isaac, big deal. Big BFD, big freaking deal. So you embolize vascular tumors, just embolize vascular tumors and move on. And let's just not talk about this. But actually, if you pause and stop and think about this, This opens Pandora's box to moving forward in the future. First of all, by the way, Mike and I know this, Mike and I, we didn't touch a single coil or endovascular anything during our residency at UCSF. Okay, we didn't we didn't embolize anything. Okay, I don't know if Mike does now. I sure don't now. So we don't do this. But there's another side of this question, which is all the interventional radiologists, neuro IR people, all of my friends. I have dear friends who just love endovascular surgery. Okay, Milan, if you're listening, he's one of my residents, just loves endovascular embolization. The question from that side is, what materials? What's the best embolization? Is it glue? Is it particles? You know, there's a whole sphere of that. I can't speak to that because that's not what I do. But I can speak to the opposite side of this, which is, so if you're going to embolize, so you come away and go, okay, Isaac, I buy it. I'll do ITK snap. I'll do MVI. I have a tumor. I have a patient. I want to optimize the outcome. The MVI is high. I embolize it. Isn't that what you're saying? No, I'm saying this opens a second window of questions. Like, when do you embolize? How important is the window between embolization and actual surgery? Back when Mike and I were residents, we used to embolize with Dr. Michael McDermott. We used to embolize tumors 1 week before surgery, send them home, and they'd come back a week later and we do the surgery. And because I was a resident, and that's the way Andy Parsa did it, and Mitch Berger and Manish Aghi, I thought that's the standard of care. When I came to UCLA, I found out that Neil Martin, he used to embolize all his tumors the day before surgery. So I said, okay, that's the way it is. And there's a varying window between, well, is it 1 day, 2 days, 1 week? How much swelling around the tumor can you tolerate? And does this change not just the bleeding factor, because we're only looking at one aspect of this, which is the EBL and blood loss and what's the risk of a blood transfusion? But the next question is, can it change the surgery? This is a slide courtesy of my friends, Dr. Azim Laiwala, who's a chief resident, and Dr. Maya Harari, who's a senior resident. These two are absolute superstars of neurosurgery. And they were so kind enough to share one of the cases that we did here. This is a 50-ish-year-old patient who had a meningioma surgery done in the distant past and had the meningioma recur. And there's these multiple meningiomas, and the goal of the surgery is to do one large approach to get them all. And so Dr. Laiwala, Dr. Harari, we came up with a plan and said, let's embolize these tumors. And if you see here, there's a small hypo-intense blush here that you can see after embolization, that you can see a physical change in the tumor after embolization. So we did an MRI after embolization, and this is the MRI that you got, and you saw a physical change in the radiographic characteristics. And then you watch, if you do the ITK STAP software change, you watch the MVI of the tumor go down after embolization. And then the last thing here, this was a 7-day course. So we embolized and then did surgery on post-embolization day 7, 1 week after. And these tumors were soft. And we got a near total resection with just a little bit of tumor left here on the branches of the MCA that just couldn't be taken off. But a fantastic resection, we think, because not only are you changing blood loss and you're changing the risk of blood transfusion with the transfusion and the embolization and the lowering of the MVI, the next step would be, are we changing the tumor characteristics? Is the tumor softening, and is the tumor easier and better for resection? And I think that's the future for embolization. And then the last thing, the future of meningioma surgery isn't just embolization and treatment with surgery. It's going to be molecular therapy. And I just want to put in a quick plug for this epithelial membrane protein 2. And this was done by Dr. Patel as the lead study on this research study that we did here at UCLA. And we looked at EMP2 as a molecular marker in meningiomas. And we found that an overwhelming number of meningiomas expressed this protein. And that if we could target this protein, this would be an adjunct post-embolization, pre-surgery, embolization, surgery, and post-surgery. Could this be a target for looking at residual tumors and how to target this? And so we've looked at EMP2 in meningiomas. It's the future. And I'm just going to be shameless about it. We were awarded the North American Skull Base Society research grant in 2020, right before COVID. and we're going to be presenting our research results at the upcoming North American Skull Base Society in 2023. It's in Tampa. I hope you can come. It's going to be a great meeting, and I hope you can see the results of that talk. I'm just being completely shameless about this plug. I need to thank all the members of the Yang Lab, including Shayar and Mahi, research fellows that have been with me for 2 or 3 years, that have done the David Goliath big share of this MVI research and work. And I'm so honored and blessed to be a part of this team. They're fantastic. And really, this is the team that really gets the lion's share of it done. And yeah, they run a lot of the social media and the outpouring and the data dissemination. That's also really important. So hope you like it and follow it on the social media as well. As Mike was saying, this thing started during COVID. Social media became more important during pandemic. I think these things are going to be important and more important in data dissemination as we move forward. I don't do this alone. I'm part of a wonderful program here at UCLA. I always tell Dr. Ivan that Los Angeles, in my opinion, is the only city better than Miami. But yeah, I have a wonderful team at UCLA, including Dr. Linda Liao, Marvin Bergschneider, Juan Kim, and Rich Everson, the great brain tumor, the oncologist, Dr. Clausy, Lion Nimfu, the ENT colleagues we have here, the radiation oncology. It takes an army of neurosurgeons, ENT doctors, radiation oncologists, and scientists. I'm just so thankful to the entire team. And if you have any questions, you can always contact me. If you're old, you can email me. This is my email. If you're young, you can DM me on Facebook or Instagram or Twitter. I'm always available. And thank you so much for taking the time to listen to me.
Awesome. Thanks so much, Isaac. That was really, really interesting. I appreciate you tackling something that's definitely a little bit controversial and kind of providing a lot more insight as to and clarity as to when we're actually supposed to be doing this rather than just all sayers and naysayers, which is kind of the two sides of the coin. It's if you can be precise about it in these instances is really, definitely helpful. Before I want to get to some of the questions here before we get to a couple of cases. We have a question here from the audience. What's the advantage and disadvantage of using pre-op Embo with different kinds of, I guess, they have different kinds of types. I think you alluded to this of embolization.
Yeah, this is how the question started. Was I had a posterior fossa tumor and I wanted embolized, and I guess the wire breaks, or is that how it happened? And I apologize for being so naive and I apologize for being stupid when it comes to the coiling and the endovascular, because I have no experience. Mike, do you have experience? No. Okay, so we train at the same program. So Mike and I are both, we just don't know about. Anyways, the coil broke, and my good friend Nestor Gonzalez, he was part of that case, and he's like, well, the coil broke in the tumor. Just fish it out when you see it. And I was like, Nestor, I don't know what it looks like, man. Like I literally will not know what it is when I'm there. So I actually exposed and then called Nestor and said, hey, come in and help me take this thing out, because I don't know exactly. I was trying to make sure it is. And he goes, it's that, dummy. And I was like, oh, you're right. That's it. And so then we took the fractured wire or coil, whatever it is, we took it out, and then we took the tumor out. And I was like, oh, this embolization thing, it's not without complication. And then because I started, remember I told you, back when I started, I thought I knew everything. You come out of chief residency, man, you just think you know everything. You just come out with that bravado. I just thought I knew everything. And what I didn't realize was, no, actually, I had a lot to learn. So I learned from, my UCSF teachers embolize a lot. Neil Martin was a heavy embolizer, so I embolize a lot. But then as I was going through my practice, I realized there was actually a lot of maybe non-clinical sequelae. So there was a fair number of patients who had scattered T2 signal post-operative after gross hole resection, not clinically relevant, but on the follow-up MRI, as I saw these patients, and see, as a resident, I just did the surgery. I wasn't following them in clinic post-operatively and seeing the issues that could occur. There were no major clinical issues, but when you see scattered T2, MRI signal after post-op gross total, and they're wondering why that happened, and you're thinking, that's not from my surgery, that this embolization is not by itself benign. And just in the conversations, like Mike said, there are naysayers and sayers, and there's like, well, that's just middle meningeal. You could just sacrifice that on your way in. Well, actually, for some of these tumors that are midline, you have middle meningeal features from both sides. And so, can you take them on both sides and things like that? And so the question came about, well, maybe I shouldn't be embolizing all of these. So if I shouldn't, And that makes a lot of sense. Is the naysayers like, don't embolize anything. I'm like, okay, that makes sense too. Maybe I should be more judicious. And that's how the question first started. Okay, well, do I need to? Is transfusion an issue? And we found that, nowadays, all the older patients and smaller meningiomas, a lot of them are getting treated with radiosurgery, which I think is fine. And that's becoming more and more the standard because they're older or they're smaller. But for the ones that are remaining in surgical, these are happening in young patients with big tumors. Those are the ones that are becoming more and more surgical because those are the ones that are remaining and absolutely have a surgical indication. Well, those patients will now requiring blood transfusions because as the tumors approach 5 centimeters, the surgery would approach 10 hours. So then transfusions become more critical. So then are you going to go through and embolize all of them? And I first thought the question was just going to be, I thought when we started this, the answer was going to be, it's just the big ones. It's the size. The size is all that matters. But what we found was very similar to acoustic neuromas, that sometimes size is not everything. And so that we found that some big tumors had low MVIs, some small tumors had high MVIs. And then the flip correlation was going to be calcifications. I thought it was just going to be calcified tumors, that the calcified tumors are just rocks and they're not going to need it. That's some component of it, but it doesn't capture actually the need for transfusion. It only helps you capture those tumors that probably be lower in vascularity and blood transfusion. So the MVI is what we came up with. And what we've now found out through 2 rounds, one that is published, and the second one that we hope to publish shortly, is that even through a progressively larger series, it's finding out to become more important, and it's becoming more important than tumor size. It can help you find out which tumors are going to bleed more. Even if you're against embolization and you're like throwing tomatoes at your computer screen and you hate me, that's okay. I'll buy you coffee. We'll sit and talk. But my thought is it'll at least help you figure out which tumors are going to be harder to wrestle, that are going to bleed more, so that you can recognize this. And then moving forward, the next generation of neurosurgeons are going to say, well, Isaac, that's so obvious, duh. And they're going to develop computer algorithms and apps on their smartphone that'll just look at the tumor and then come up with a number and an algorithm on their own, so that they come up with a future index that identifies which of these meningiomas are going to be vascular and bloody and which of them are not going to be.
And I wanted to ask you, there's obviously some areas that you can't really get a good embolization. So if you have a planum or a clinoid, it's feeding by ethmoidal. Those are kind of vessels where you're going to get a lot of pushback. So do you have kind of a subgroup in your head of these are the ones that, with a high MVI that then go to angio, or do you just MVI is high, they all go to angio because I'll learn something from the angiogram, even if they can't do the embolization?
Yeah. And it's hard for us as neurosurgeons, I think, to talk about these things. And, I'm so blessed here to have such awesome colleagues like Jeff Colby, like I told you, Nestor Gonzalez. Now we have Jeremiah Johnson. There's a flip side of this, a side that I don't talk about, that Dr. Ivan and I don't talk about, which is looking at the embolization side of it, the vascular side. We Dr. Ivan posts this on social media. It goes out. They post this on my Facebook, and Pekka Talk, he made a comment on this talk going, well, it all depends on your neuro IR team. He's right. He's right. And I'm so blessed because I have Reza Jahan here, Duck Weiler. I have phenomenal IR doctors. I mean, really the best of the best. And the fact that they were even getting some T2 signals on some of these embolizations is just, it's really, they are awesome. They are phenomenally good. And so really, in order to have this conversation, is that you have to make it multidisciplinary. You and your neuro IR team have to become one, because there's a limit to what they can embolize and what you do. And when you ask for it, they have to be able to do it, or they have to be able to push back and say, no, this is not one that needs it, irrespective of the MVI. Yeah, depending on where the tumor is. And also, I see the argument back when sometimes they're like, well, that's a convexity, that's sphenoid wing. I can just take the middle meningeal on the way in, no problem, Isaac. Don't embolize that. And I can see that. You're totally right. You can just take out the middle meningeal on the way in, and the bleeding will be less. But it doesn't address question 2 or 3, which is, for the future generations, you'll look at embolization and not just look at rudimentary things like me, blood transfusion, the EBL. You're going to be looking at future things, which is, does it make the tumor softer? Is there a certain pathology, radiographic marker, or post hoc? Is there a protein marker on certain meningiomas that make them have a higher angiogenic factor, which we believe EMP2 could be, that makes them better targets for embolization? And then if you wait and you embolize, what's the window? Is it supposed to be 1 day? Is it supposed to be the weekend? Commonly now I do about 3 or 4 days. We embolize on Friday. I'll do the surgery on Monday. And if you push it, can you do it the way we used to do at UCSF, which is embolize on Tuesday, surgery next week, Tuesday? It's 7 days. And does it make the tumor softer? And does it make the resection easier? And then, as Dr. Ivan alluded to, there are notoriously particularly hard tumors to embolize. I think the planum ones in particular are hard. There's just a lot of important blood vessels, including eyes, ethmoidals, and just getting into that access space. If there's complications there, they can be quite significant. But on the flip side, I've had a lot of posterior fossa meningiomas embolized, and I think it makes a big difference. And yeah, even for that convexity one, the argument could be made, it's convexity, you don't have to do it. But Dr. Harari, Dr. Laiwala, my chief resident, senior resident, they brought up the suggestion. This is anecdotal now. This is not studies. We don't have 80 patients that we're looking at. It's anecdotal, saying, look, it makes a difference. It makes a signal change on the MRI, because normally if we do the embolization Friday, we don't get an MRI before the surgery Monday. So we don't have MRIs after embolization, but we're talking about doing that. One of my colleagues, Rich Everson, who's also a brain tumor surgeon here at UCLA, we're talking about, okay, is there something we need to look at? And do we need to change the protocol and look at the enhancement characteristics after embolization? And will that affect future treatment? And so I think it's really opening up a whole box of future research for the future neurosurgeons.
Laker, did you want to ask a question?
Yeah, no, Dr. Yang, this is awesome. And, you know, I hope to see that like in 5-10 years, we look back at this and are able to see as one of the things that changes into the future, one of the things that lets us know, because embolization is definitely a huge question. Have you found kind of, you say you're changing your protocol as you go along. One of the things that I was taught coming across was there's some concern of swelling, especially for the larger ones. So, you know, have you found this? Is there certain scenarios in which you would wait longer or shorter, depending on the size of the tumor, how much edema that's already present on the tumor, versus how soft you want the tumor to become and change its characteristics?
Does it suck that my answer is I don't know?
Yeah.
And that's why that's the question that has to be answered. You're right. Right now in 2022, if there's a lot of swelling, I'm going to try to shorten that window. I may not embolize at all. And if I do embolize, I'm going to embolize the day before surgery if there's a lot of swelling. Is there any science to suggest that? No. I just act like I'm an attending and I know everything. And yes, let's embolize that day before surgery because there's swelling. Is there any science to this? No. No science. Yeah. It's just my gut. There's no research, but could it be wrong? Yeah, it could be wrong. Maybe those are the best ones to wait the longest and then put them on high dose Decadron and then have those tumors just come out so softly because the brain's so friable. It's so edematous and friable. That's the one that you need to be super soft. Maybe that's the answer. Maybe it really is. Sometimes what you think is the right answer is actually wrong. You know, now doctors used to prescribe smoking. This is true. Don't take my word. Look at 1950s. Google it, right? Yeah. Doctors used to prescribe smoking to their patients in the hospital. And what they thought was right was actually wrong. And so we don't know. And so you're asking me what I do. You're right. It makes me nervous. When I look at a lot of swelling, I may not embolize. And if I do, I make a very short window. That's why that case from Dr. Harari and Dr. Laiwala, there was not much edema. And so that's the perfect case, embolized, way that we can take out. But honestly, I've gotten away with some swelling in some cases, and I've waited longer and longer and longer. I just don't know the perfect window. And then I don't know the actual effects. I don't know how much softer it makes it, how much better it makes resection. And then the ultimate question is, does it make it better for our patients? Like, is it actually better? Is it not just easier for the surgeon? Because if you prove that the outcomes are better and the patients do better with less swelling, less neurologic deficit, and greater resection scores, you just found the next level of questioning on how to help our patients.
Absolutely. I do think that would be very helpful. Thank you. I also have a couple of cases we'd like to present. Yeah. If I could share the screen if you.
Go for it.
Awesome. So, first one is a clinoidal meninge. I mean, that's not the secret here, but I wanted to see how you would approach this. So 29-year-old male presented with headaches and somnolence. He does have this history of childhood cancer, mixed germ cell pineal tumor at age 12, has ETV, shunt, chemo, and also had 50 gray of partial radiation over 25 fractions. And he comes in fairly confused, oriented times 1, some exotropia, delayed speech, and follows simple commands. And when we got the MRI scan, this is what we find, which is fairly large. I mean, I didn't measure it, but it looks like 6 centimeter kind of mixed density, especially in that lateral posterior aspect with some phlovoids in itself. Meningioma with significant perilesional edema. And something we wanted to look at was, as you had noted, the T2 signal here on the left side. We also had a CT with contrast, or CTA rather, which is the kind of the more traditional way we looked at, vascularity on these things, as well as this CTA recon that you could see that there's quite a substantial blush that you see there. Is this one you would say would be significant and that you would definitely embolize, or you hope to embolize going in?
Yeah, excellent question. That's exactly the thing. Like you said, right? You smiled. That's what we're looking for. That's what we try to teach our residents and our fellows. Look for the T2 tumor voids. But what you're looking at right now is one axial slice. You're not looking at the volume of the blood vessels. And as a blood volume and in total volume of 2 or 2.5 cc's, that's what the MVI is looking at T2 in a 3-dimensional volumetric assessment. The second thing is you're showing there, that's the internal carotid, is that the internal, the left middle cerebral artery injection, is that what you're showing? You're showing the 3D, and then you're showing the left middle cerebral right here, is that correct?
It's a recon of all.
Yeah, it's a recon, vessels, I think. And you're seeing the tumor there over the left middle cerebral. What we really want to know with the angiogram is how dependent is it on internal circulation versus external carotid circulation. That's really the crux of the matter. And once they can figure that out, whether it's ECA or ICA, which one is it more dominant in, then yeah, I would strongly see, because I would ask my interventional radiologist to see if they can get down there to something. Now, this is where it starts getting dicier, because this is why you're putting it there, because you make an embolization error here and you're going to get neurologic sequelae. You're going to end up with infarct on the left insular region, or left motor strip, and you're going to get some significant weakness. The second thing is this tumor is very large. You can see a shunt here, right occipital shunt. So the patient already has a shunt. You're inviting some sort of sequelae that this is a large tumor. So then if you take it back and say, okay, I don't know if you should embolize, the second thing would be take it back to my other rule, right? This more simplistic rule. If you can't do the MVI, look at 5-10. Do you think the surgery is going to take you 10 hours? I think even in Dr. Ivan's hands, it's going to approach 10 hours. Probably do it in 6, right? But it's going to approach 10 hours. And the second thing is this tumor 5 centimeters? I think it looks about 5 centimeters, maybe a little bit bigger. And the last thing is this guy's a young patient, right? I think he's 24, 29. And this is a radiation-induced meningioma. Yeah, I need to call timeout, throw the red flag, NFL film review, instant review. We're talking about a different beast. If you're looking at radiation-induced meningiomas, this is going to be a very different surgery than a de novo or take the same meningioma in a 29-year-old female who did not have radiation, this size, same location. Even though they're both classified as meningioma, and we stopped talking about gender and age. And remember, you said this was male, right? So already radiation-induced, atypical, you're talking about different beasts. And we walk around and look at your title slide, left clinoidal meningioma. Yeah. Yeah. Do you do an extradural clinoidectomy, intradural? I'm like, no. Pause, slow down. We're treating them as if they're the same. And I would stop and pause and say, no. The only thing same is McDonald's, by the way. McDonald's is great. I love McDonald's. But McDonald's, same Happy Meal every time you go. Any country you go, anywhere in the world, there's a McDonald's, you know what you're going to get. Neurosurgery is not that same. Neurosurgery is not that way. And so because of that, this, even though you're calling it meningioma, is very different than a de novo meningioma in a young woman that approaches in the same area. Radiation induced, hypervascular, it's large. I would strongly recommend IR with my team, as long as you believe in your team and they are on the same page with you. And because of the size shift and swelling, maybe shorten the window between embolization and surgery. I think, in my opinion, anecdotally, the embolization will help you take this tumor out. And you have to go for big surgery because he's young. It's radiation induced. Radiation can't help. You got to go after gross whole resection, even if it puts the patient at higher risk for the greater extent of resection. You got to go big here. So this is a hard case.
Absolutely. I can show you a little bit of what happened. I mean, kind of semi to prove your point, ended up doing left OZ resection, just kind of really get into it. Was extremely vascular, especially at the clinoid. Had to stop the clinoidectomy, and the estimated blood loss came out to be, still got a great resection, maybe a little rim at that very medial posterior border right there, but about 1.5 liters of estimated blood loss or reported blood loss. And turns out it's a grade 2 atypical meninge. Now, the patient did great, a little bit of a hospital stay because of the blood loss, but from a neurological standpoint, did great. But in some ways, this shows you a little bit of that length of case, the estimated blood loss, the difficulty of the case that's going ahead.
Yeah, and then in hindsight, if you embolize that, then would you have lost less blood, and would you have needed blood transfusion? Maybe. The answer is maybe. That case would have been hard no matter what. But you just highlighted the experience of every tumor surgeon in the country is that they go in and tackle this. I think the OZ is perfectly the right approach. We talked about the clinoidectomy. You're going to have a lot of blood loss. This tumor is going to be a beast because it's radiation induced. And could you have known that before? And you walk in knowing it's going to be bad, but sometimes you have tumors that look just like that, and they come out in a different way. And so not every meningioma is a meningioma.
Mm-hmm. Absolutely. Dr. Ivan, do you want to add anything, or I can go on to the next one?
Yeah, no, I mean, I think all those points were exactly kind of what we wanted to hit.
Do you do an intradural or an extradural clinoidectomy, Mike?
Yeah, I prefer to do all bone work on any of these meningiomas as much as possible, extradural. I really try to not only just do the extradural clinoidectomy, but really actually open up the hycuba plane and try to strip the dura off of the cavernous sinus. And that way you could cauterize as much as the dura around the external part of the tumor as you can before you open up. I think we knew that this one, based on the vascularity beforehand, was going to be a tough case. And we actually had a long talk. There was some controversy on whether or not, an Embo would be helpful here or not. And so it was interesting to kind of see. But in the end, it was just a tough case.
Yeah, because that 3D recon shows the internal supply to it. The only other supply I want to see is the external supply to see if it was significant.
Right, which was the argument was that, on the way in, you're going to get it. So,
yeah, and I know that argument, that's a common argument. I don't know.
Yeah.
Awesome. I have a couple more. So this is a 45-year-old female, no major past medical history. Notice a slight change in her handwriting. Of significance here, she's left-handed, and on MRI scan has this large pedunculated right sphenoid wing meningioma, and of significant, measuring anywhere from, I would say, 6 centimeters to 4 centimeters in size, significant midline shifts, as you could see there. And this is one we do have a nice T2 on. What would you think of this at the end?
So this is the exact opposite case that we were just talking about. So this is meningioma in a woman that's likely to be grade 1. I can't do the MVI because I'm not computer software, but when I look at that T2, I do not see substantial, back of the envelope calculations. I would guess that the MVI for this tumor is going to be low. So this could be one that you don't have to do embolization on. There's a lot of edema. This tumor is large, but again, here I would not consider embolization as my first go, only because I would say, look, I'll put it through the software. By the way, I don't have any stake. I don't have any, I don't buy any, there's no commission here. It's free. It's all, open access. you get the software, you run it, and you see the MVI. And if the MVI is low, which I suspect it is, then yeah, this is a case, even though the tumor is large, right? Back in my residency, I would have been like, heck yeah, embolize, it's big. But this is a large tumor, but this is a large tumor that's going to have a low MVI. And because it has a low MVI, I suspect that this is not going to bleed or not bleed as much. And so that this tumor surgery will not be substantially helped or changed by embolization. So I would just do a standard, terional or craniotomy and approach this and just go after this. It's going to be a long surgery, because you're going to try to preserve and peel it off. But, you can already tell that there's some CSF planes here. So at some margins of this, you're going to have really good planes. There may be minimal brain invasion. And so this surgery may be, even though it's a bigger surgery, it's a complicated surgery, this may be a little more straightforward. You may be able to get excellent resection over a long time with lower blood loss and very little EBL and no transfusion.
I think for this one, because of the size of it, and I'm curious to see what the NBI would be. She did undergo an embolization, and we were able to get actually a great embolization. So I'd be curious to know what it would have been without it, or what the changes. So this is the pre-embo external carotid run right here. You got an AP on the left and a lateral on the right there, and this is a post. And
then what was the window between embolization and surgery?
I believe it was 6 days.
Yeah. So then how many days is it?
Day before. I apologize.
Day before. Is it supposed to be day before? How many days? These are all questions that soften the tumor, and when it made the ABL less or worse. Is that right now we don't have a good marker for when and when not to. But yeah, I don't think it's wrong to embolize. It's a big tumor.
Yeah, and interestingly, we have a post-op MRI afterwards, and I don't know if it looks a little different on this T2 imaging. It's hard to say for sure.
Do you have a team one with contrast after embolization?
Oh, I probably do. I unfortunately didn't put that one on here.
That's the reason why Dr. Harari and Dr. Laiwala sent me that photo, because we actually have documented enhancement change after embolization.
Pattern change, yeah.
That's also something that's unknown. You're in uncharted territory, man.
And this one, we were able to get 200 cc's of blood loss, and it's hard to know, would that have been worse beforehand or not? So who knows at this point? And hopefully your research solves it.
Yeah, and I don't know if it's my research that solves it, but that's the question. Is I'm here and saying, okay, you just walk around going, yeah, embolize, I got such a great result anecdotally. But what I would gently suggest is actually for this one, if you could go back and clone yourself, I wonder if you had just taken out with an embolization, you would have got the same 200 cc's. There's got to be some way for us to answer that question better, because right now, we're having all these smart people on the line and we're approaching it in this kind of haphazard manner. I think there's got to be a more radiographic AI computer, deep learning way to approach embolization and how we approach meningiomas.
Mm-hmm. And there's one more we're thinking of, but
we could skip the last one, actually. I actually have
I'm gonna stop my share then.
I have one more though, just to kind of bring up the point that we were discussing. Let me just see if this is it. Oh yeah, you can see that, right? Mm-hmm. So just to kind of to shift a little bit gears to the skull-based tumors a little bit more, because I think there's also, like Isaac, I was taught all these petroclival meningiomas. We would get angio and embo when we were resident, and then when I came here, there was a lot of it wasn't quite the way of the sword, so to speak. So this is so here. This is one of the patients I had really early on, right when I started. 60-year-old female, large petroclival meningioma with neurological symptoms. Again, the T2 not impressive down here, but a large tumor. It's going to be a long surgery. So I got my preoperative angio, and they said, well, yeah, we're going to embo the external ECA feeders, ICAs, the tentorial artery we just can't get to. And so, we did the surgery. We did all in one day, super long case. They didn't really get a lot of the feeders, and long EBL and 14-hour case. So moving to kind of the next version, this is a little bit of a different tumor. This is like now a year ago, so a little bit more experience. Lots of weird density changes on the preoperative contrast scan. Very similar story though on the size of the tumor and as also the symptoms. And this one, we ended up doing a two-stage approach where we ended up just doing all the bone work the first day, because I was kind of saying, well, after about 10 of these where they haven't really emboed the internal carotid feeders to these tumors, they're just getting the external carotid. Why don't we just stage this and do the bony work on day one, embolize all the, cauterize all the dura, let it sit for a day or two, and then kind of come back like you're saying, and see if that softens the tumor. And this is one where we got the T1 contrast. It was like 36 hours after we did the bony work. And you could see here that there's this kind of really significant darkening in the middle. Obviously there was some changes there beforehand, but this was extreme. Even on the T2, you could see it was like almost a hemorrhage kind of, but not a real hemorrhage that was happening here. And you could see this is the bony work that we did on day one. And then we went back day two, that whole middle section was super soft, super succible. And basically just all of that kind of debulking was done within the first 30 minutes. And then you could spend, you're energized, you could spend your time doing the rest of the case and peeling it off. We were able to do this in half the time, less than a quarter of the blood loss. And it wasn't emboed, but it was the same idea that you're saying, is that we're tackling the blood supply early. We're giving the chance for the tumor to kind of relax and kind of devascularize itself, and then going in. So I don't know if you're kind of include that into your algorithm going forward, but I think for some of these combined cases, this has a very similar approach to the pre-op angio embo.
That's the exact same principle, Mike. Yeah, he touched on so many things. First of all, the learning curve of an attending neurosurgeon. Mike was talking about is that you just keep getting better. We're better now than we were 10 years ago, and we should be, because we're constantly pushing the envelope. If you stop getting better, then you got to retire. It's time to hang it up. So you got to keep getting better. But the second thing is, like he mentioned, he has radiographic evidence of tumor change, and that's not some area of the, like, we're not used to getting MRIs after, like, Mike caught this because he did this in the staged approach, right? So if you do this in the staged approach, then you see all that, because he was talking about, he does all his vascular work and bony work preoperatively. He wants to bipolar the dura, and he wants to take out all the extradural supply as much as possible. And then he got the imaging because it's staged, and you can see the changes. That's why I caught that embolization. I rarely get MRIs after embolization. We just happened to get that one after embo. It showed a change, and that tumor a week later was so soft. And you see that, and there's got to be a question, which is, which tumors warrant this? Not every tumor does. We're conceding this. This is a difficult skull-based tumor, very deep in a very difficult location. And then changing the timing of the surgery is that Mike talked about how he initially tried to do it in one stage. It's just a long surgery, but breaking it into two and doing it staged, that seems very appropriate and very wise. And then having that time to use that, whatever, embolization or, blood supply, devascularization, whatever you want to call it. It doesn't have to be embolization. I think it makes a big difference to the tumor, makes a big difference to the surgery. And I think ultimately, I hope that you all can see improve and move the science forward, is that it changes the vascularity, the softness, and just the suckability, just the ease of resection by devascularizing tumor and giving it a few days to necrose.
Another last question, and then we'll let you get back. I know you got a lot of your day to go still. This is a great question, though, by Dr. Rivas, was additionally, when you do the embolization, do you see a difference in tumor recurrence because whatever residual you may left has significantly less blood flow? And I don't know if anybody has the answer to that, but I'll let you kind of tackle it.
I think that's what we're inferring, is that if we can decrease the vascularity on the appropriate tumors, like not the gross totals, you were going to get gross totals anyway, which is, I guess, what I was suggesting on that, the woman with the tumor. But the tumors that you weren't going to get gross total, if you can raise that resection rate by changing the vascularity and devascularizing the tumor, I think it should contribute to a lower recurrence rate, better outcomes, and maybe a lower recurrence rate after gross total resection. Skull-based surgery may be different because you still have the meninges and the remnants of the tumor, and that opens up a whole different box of radiosurgery and recurrences. But I do think it makes the surgery safer. I think it lowers your risk of EBL, and I think it lowers your risk of needing a blood transfusion. And so I think future generations of neurosurgeons are going to answer this question that we're opening today.
Awesome. Well, congrats on the work. we'll talk offline, but we have some AI projects here that I think would collaborate pretty well with you. So we'll talk at CNS. But congrats to all your team and the work that you've done, making a difference, no question, in meningiomas. And we just want to thank you again for your time today.
Thanks, Mike. Thanks, everybody.
Thank you, Dr. Yang.
Thanks,
Okay,
Dr.
have a good night.
Mike.